Now we are going to do the last presentation of this session by Dr. Luis Arias, SS-OCT in vitreoretinal interface disorders in high myopia. Luis.
Good morning. Thank you, Jose Maria. At first, I'd like to thank Topcon for inviting me to participate in this outstanding conference, and I encourage them to keep on promoting these educational events. We know that macular disorders are relatively common in high myopes, such as presented by my previous speakers, but I'm going to focus on vitreoretinal interface disorders. Mainly vitreomacular adhesion, vitreomacular traction, epiretinal membrane, macular holes, lamellar and full thickness, and macular hole retinal detachment. It seems clear that a good OCT is crucial to examine our patients with high myopia. If not, many details could be missed. In these papers, the authors conclude that subsource OCT is superior than a spectral domain OCT when trying to find some important findings like vitreoschisis that can be missed if we don't get some long scans. This is a quiz. Rick, it's difficult to say who's the underdog in this quiz. Above, relatively healthy eyes. Below, some more pathological eyes. It's difficult to say what's going on in these maculas without a good OCT. Let's see what happens. All these patients were asymptomatic, no symptoms in these patients. In the first one, we can see that myopic fibroeschisis was present, very nicely seen with these en-face images. But the patient was asymptomatic with a relatively good visual acuity. Next case, again, without symptoms, very good visual acuity with this typical myopic fibroeschisis in this young lady. Another case, this was clearly the underdog in this quiz, with this relatively stable visual acuity with no symptoms, but with this clear vitreomacular traction and the staphyloma that can be seen very nicely with this subsource OCT with a long scan. With more detail, we can appreciate the relationship between the vitreous traction and the retinal surface. And the last one, this male with this epiretinal membrane, again with no symptoms. That's why it's very important to examine these patients with good subsource OCT. If not, we can miss these disorders. Vitreomacular adhesion can be very nicely seen with subsource OCT. It's very typical to observe these paravascular adhesions that they don't need to be treated, you know. This vitreomacular adhesion in this case is at the level of the optic disc. And this is a case with a vitreomacular traction with an epiretinal membrane with no symptoms. Another patient with a myopic retinoschisis that is not affecting the fovea is extrafoveal. If we don't have a long scan, it's very easy to miss this finding. And in the chapter, in the topic of foveoschisis, we know that many cases of these are stable over time and they don't need to be treated unless they develop visual acuity loss or they develop a full thickness macular hole. This man was followed for 5 years and the label was stable with no change both in visual acuity and in the appearance of the subsource OCT. This is the same case, image with en-face imaging. This is a case, this myopic fibroeschisis that later on developed a small focus of choroidal neovascularization that was treated with anti-VEGF therapy. It's possible to have concurrent disorders, to have foveoschisis, some vitreoretinal interface disorders, and some choroidal neovascular membranes as well. This is a case with a tractional myopic maculopathy, retinoschisis, with the typical retinoschisis affecting both the inner retinal and the outer retinal layers. And we know that these cases need to be treated once they develop visual acuity loss or full thickness macular hole. This could be considered a full thickness macular hole. There's still a roof of retina, but it's clearly a hole. And the patient was treated after surgery with posterior vitrectomy, ILM peeling and gas tamponade. This is the appearance 6 months after the surgery. It's important to know that the recovery in these patients is slow. Then we need to be patient to observe this slow recovery, both anatomically and functionally. Here we have a nice case with a lady that was followed for several years. This was the initial presentation with no symptoms, very good visual acuity. This was a spectral domain OCT. And over time, he developed, starting from a normal macula, this phoboschisis that was worsening over time. And finally, she developed a full thickness macular hole that was treated surgically. That was the thing that I think that is crucial to follow these myopic patients, to monitor them regularly with subsurge OCT. And this is the same case. More than 2 years after the operation, we see that the macular hole is closed and the typical dimples that are observed when we peel the ILM in the retinal surface. This is the emphase, where we can observe very well these dimples or the dissociation of nerve fiber layers, such as has been said. And in a case, the progress from a phoboschisis, from a small lamellar macular hole to a full thickness macular hole. This patient was imaged with a spectral domain OCT, and the evolution after surgery. This case, I think that it's very nice to show. They observe this large staphyloma with this very thin choroid, with this traction. This female, it was the single functional eye of this patient. 6 months later, she developed this important vitreomacular traction with a defect in the external retinal layers. And 2 weeks later, she developed a full thickness macular hole. Then she was operated on, and we get a closure of the macular hole. In another case, this male with this vitreomacular traction, with good visual acuity, 3 years later, he developed a full thickness macular hole with this typical traction, and the natural course after the surgery. Another man with this full thickness macular hole, and here we can image with the spectral domain OCT the closure of the hole with the gas bubble still inside the eye. And in this case, the hole was relatively large, and then we used the inverted ILM flap technique to try to close this hole. And after surgery, we observed the typical flap inside the macular hole bed. That can be very nicely seen with swift source technology. Another case that was managed with an inverted ILM flap technique because the hole was very large, and we had a failure in the previous surgery. And after surgery, we observed this tissue, the flap inside the macular hole bed, and we imaged the patient as well with OCT angiography and emphase, and we could observe these changes at the level of the macula. And sometimes it's very important, this examination, to determine the exact location of the macular hole, because if not, it's very difficult only seeing the fundus of the eye to say where is located the macular hole, and then we can plan the surgical plan, seeing exactly where is located the macular hole. In this case, another full thickness macular hole, the surgical plan, and the post-op appearance. And we can image these patients as well with OCT angiography or emphase. And with emphase, it's very typical to see this, the area where we have built the internal limiting membrane. And this was the follow-up of the same patient with this epiretinal tissue that was not affecting the macula for the moment. Another case with a full thickness macular hole, still with some remaining tissue on the roof, with a clear defect in the outer retinal layers. After surgery, with the gas bubble still inside the eye, and observe this close closure. What happens with lamellar macular holes? It's very similar to foveal schisis, with a stable visual acuity, with a stable appearance of the SS-OCT. We don't need to go to the theater with these patients. Many cases can be stable over time during many years. And it's important to have different projections, different scans, because the appearance of these vertical scans seems to be more lamellar macular hole, but in this horizontal scan, it seems more to be a pseudo membrane, a pseudo hole. This case progressed, and then we operated on this patient. Sometimes after the operation, we cannot get a very nice close-up of the hole, but functionally, these patients usually improve. And a lot has been said before about Duchenne macula, but we know that this entity is relatively important and common in patients. We know that fluorescein angiography is not very good to follow these patients because we don't have a lot of information. And with the spectral, when SS-OCT, we have the typical findings that have been explained very well before. I'm not going to go in detail with that. And in this paper, that is interesting, we know that corneal neovascularization, myopic corneal neovascularization is a relatively very common condition in these patients, but the results of our treatment with anti-VEGF therapy can be affected by the vitreomacular interference disorders, and it's important to take this into account. And this is a patient with a very early myopic CMV that can be very nice image with this SS technology, assisted with OCT angiography and MFAS. And in this case, it was a case with a very small early CMV that you can see that can be imaged with this multimodal approach, only with SS-OCT, fluorescein angiography, and MFAS. We observe the same spot with MFAS and with the fluorescein angiography. And staphylomas, Professor Ruiz Moreno has explained very well that I think that the SS-OCT can play an important role to try to classify staphylomas. We could have some very nice reconstructions of these cases with SS-OCT. And we studied that the axial length and the presence of hypoautofluorescence with foveal involvement seems to be bad or worse prognostic factors for visual recovery in patients with macular hole retinal detachment. In this case, you can see this staphyloma, this double staphyloma affecting the fovea and the nasal to the optic disc with this macular hole retinal detachment. Then we put a buccal, a macular buccal in this patient, and the buccal was not very well located. And you can see that with a spectral domain OCT, we miss this information, but because we cannot see at the same time the position of the buccal and the macula, but with SS-OCT, we're able to see what happens in this eye. And in a case with a macular buccal, then we can observe that the macular hole is closed, but still there's some fluid in the inferior part of the retina. And as well, it's very important, this technology, to try to monitor the post-op. Such as I said before, in many cases it's difficult to locate the exact location of the macular hole, and with SS-OCT we can manage to do that. Then we could say that, without any doubt, SS-OCT is superior than spectral domain OCT to image vitreoretinal interface disorders in high myopes. We have longer scans, better visualization of the vitreous and the retinal surface, and better post-op monitoring. Thank you so much for your attention.
We are going to open the discussion. Please, if you wish to do a question, raise your hands or send us the question. You want to start?
No, you can.
Okay.
Oh.
For Luis Arias, in case of foveoschisis, it seems sometimes that the retina is shorter than the sclera. Vitrectomy plus peeling plus gas is effective in these cases?
I think that these patients has to be very well examined before taking them to the OR because, such as we pointed out, many cases are stable over time and they don't need to be treated unless they develop visual acuity loss or a full thickness macular hole. With SS-OCT, we can image very well the location, the exact location of the fibroeschisis, if it affects the central fovea, and the relationship with the vitreous surface and the outer retinal layers. But I think that in general, when we operate on these patients, vitrectomy with IM peeling and gas tamponade is a very effective technique with very good results, both anatomically and functionally.
Another question more for Luis Arias. Can SS-OCT penetrate the gas tamponade?
Yes, it can. You know that sometimes it can be difficult depending on the patient, but we can image these patients in the early post-op. That's a clear advantage of this technology. We can image much better patients with oil, tamponade with oil, but with gas it's possible in the first week or second week after surgery to see the macula.
Okay, please.
We have a question asking about the role of Bruch's membrane in the elongation of the eye, as Prof. Ono Matsui described in the last review. And what do we think about it? Well, I think that the Bruch's membrane does have a significant role. As I said earlier, we don't really know for sure the individual contribution of the different parts of the eye in the development of posterior staphyloma and the development of myopic macular degeneration at this point in time. If you look at the scans of almost any myopic eye with areas of patchy atrophy, you will find areas where there are defects in the Bruch's membrane. Whether it's really related to the atrophy or in these particular eyes that Professor Ono Matsui described in dome-shaped macula, I think she's suggesting that there is a rupture of the Bruch's membrane because of the inward protrusion and the inability of the Bruch's membrane to stretch adequately. Yeah, perhaps there's such a role, but at this point in time it's hard to conclusively say what that role is.
Okay, now question is, please explain what is a Fuchs spot, how does it look on OCT, and is this eponym confusing? Should it be replaced by a described term that tells us which actually Fuchs spot is the scar, is the cicatrization of choroidal neovascularization, which is evolved by retinal pigmentary epithelium. This is a evolution of natural evolution of a choroidal neovascularization. I think the concept is clear, is the final natural evolution of this concept. Okay, all agree?
Yes.
For all of the speakers, what is the treatment of dome-shaped maculopathy with subfoveal fluid? Does it has anything in common with central serous chorioretinopathy? Will PDT work?
I generally try to avoid PDT in these eyes, in highly myopic eyes with already compromised the choroid function, and we know that in long-term PDT can have a long-term impact, so I would not do PDT if possible on these eyes. Yeah.
Your opinion, Luis?
I think that many treatments have improved with relatively low success. Perhaps low fluence PDT is the more popular one, and in selected cases with an important amount of subretinal fluid can be attempted. But I think that perhaps the subretinal fluid accumulation under the retina is more related to the anatomical defect itself, more than a CMV activity or something like that. That's why the response to anti-VEGF therapy or to the same PDT is relatively poor in these patients. Well, I think that it doesn't make sense. Why?
Thank you.
It's not a problem of traction in the retinal surface, you know, that vitrectomy peeling could be attempted if you can see some traction over the retina, but if not...
Well, I'm glad that you say that it is so, but I guess that probably somewhere, sometime, someone tried it. And I was curious to hear if anyone was daring enough to report what came out of it.
In my experience, I have treated a lot of patients with down-shaped maculopathy, with PDT, with eplerenone, with intravitreal injection of anti-VEGF. I have never have success to treat this patient, but I never tried to do peeling of internal limiting membrane. Maybe it's one option.
Well, I share your experience.
No.
No, I have no experience.
We had some patients that were treated with low fluorescence PDT, and very curiously, we saw that if they had fluid in both eyes, there was a resolution of the fluid in the fellow eye that was then treated, and the eye treated was still with fluid. And in many cases, the fluid doesn't affect the visual acuity in a very important way, and the visual acuity can be very stable. And that's why I think that no proven treatment has been done for this condition so far.
Okay. One more question for all the speakers. Do you think that a deeper scan more than 2.5 millimeters will be a clinical importance in myopia? If yes, what is the limit, 4 millimeter or even more?
I think that already we can scan quite well all these highly myopic eyes. It's only a small number that you may not hit the posterior edge of the sclera. So right now I think it's quite decent. Of course, if you have a higher, deeper penetration, that might help with very highly staphylomatous eyes.
Luis?
Yes, I agree with her. I think that currently the technology we have is sufficient to image these patients, and the information we have, I think that it's relatively good to make decisions.
I think it has been very clear show for all the presenters that the deeper penetration of SS-OCT offer us a good quality of images of very high, very deeper staphylomas. One more question about therapy of down-shaped maculopathy. I think it has been treated before. One question, vertical scans are also pathological in type 5 staphylomas, not only in down-shaped maculopathy. Please.
Such as you pointed out in your presentation, that depending on the scan, you can see or you can miss the staphyloma and the down-shaped macula. That's related to the anatomical profile of the high myopia patient.
In the majority of high myopic patients, the vertical scan is concave regular, but in some cases with irregular staphylomas, it's necessary to do the vertical scan perpendicular to the border of staphyloma, and you can find different pathologies in these special cases.
Yes, I agree. It's because the staphylomas can occur in different locations, so sometimes you need to look at all the different scans to look for the pathology. Sometimes it's vertical, sometimes it has to be diagonal. It all depends on the pathology, the structural change.
It's very important to move the position of vertical scan to do perpendicular to the border of staphyloma.
I'd like to say that in down-shaped macula, in some cases, they can develop a choroidal neovascular membrane. That's why it's important to rule out this complication once we suspect some visual acuity loss, or we observe some irregularity in the scans and perform fluorescent angiography. Yeah.
Thank you, all the speakers, for very good presentations. Now we are reference time.